Good evening, everyone. Welcome to our Life in Motion monthly webinar series. I'm Caitlin, and tonight we have with us Dr. Stuart. Dr. Stuart is a highly skilled physician specializing in physical medicine and rehabilitation. He brings extensive expertise in non-operative orthobiologic medicine, interventional pain management, and electrodiagnostics, all dedicated with one goal in mind: helping people move better and feel better. He is originally from Memphis, Tennessee, where he attended the University of Memphis, earning a bachelor's degree in biology. He then obtained his medical degree at Edward via College of Osteopathic Medicine in Virginia and went on to complete an internship in family medicine at the Naval Hospital in Jacksonville, Florida. Commissioned into the United States Navy, Dr. Stuart served for 15 years, holding roles such as Battalion Medical Officer and General Medical Officer. Later, he completed his residency in physical medicine and rehabilitation at the University of Arkansas and became a fellow of the American Academy of Physical Medicine and Rehabilitation. Driven by a passion for patient care, Dr. Stuart is dedicated to helping others reclaim their strength and independence through innovative, non-surgical solutions that enhance mobility, relieve pain, and improve quality of life. This evening, he'll be decoding sciatica.
This topic is an interesting one. It's one I hear quite a bit about in clinic and just in conversations with folks in my day-to-day life. Obviously, many of us have heard of sciatica before, right? And it's important to kind of understand what that is. So strictly speaking, sciatica is a painful condition involving irritation of the sciatic nerve. The sciatic nerve is a peripheral nerve within the body and extends just under the buttocks and down just to the back of the knee, just above the knee joint itself. Now, sciatica can be either irritation of that nerve itself or irritation of some of its component parts.
Awesome. So what causes sciatica?
Yeah, and sciatica is an interesting one in that there can be a number of different causes, right? Probably the most common cause that we see here in the clinic is that of a bulging or herniated lumbar intervertebral disc. Now, when that happens, you get irritation on the nerve root, which is a component part of the sciatic nerve, but not the sciatic nerve, right? It's what makes it up. And typically, when that happens, you will have pain within the distribution of that nerve. Now, there can be a number of other causes for sciatica. That's the kind of head scratcher sometimes, right? So it may not be just one thing. It can be due to irritation or compression of the nerve anywhere along its course.
Awesome. So do you want to look at some anatomy real quick? And
let's kind of describe what we're talking about here.
All right.
So the picture we're seeing there is actually a representation of the sciatic nerve as well as other nerves, but the sciatic nerve as it courses down basically the back of the femur. You can also see in that picture some of its component nerve roots more up by the spine, as well as some of its branches further down by the knee joint.
So how many nerves make up that sciatic nerve?
Yeah, and that's a good question because oftentimes we have to focus more on what makes up the nerve to find the actual cause for the pain. Mm-hmm. So primarily that's made up of contributions from the L4 through the S3 nerve roots. We tend to focus more specifically on L5 through S2, but L4 also contributes some fibers to the sciatic nerve.
So going a little bit more into detail, we talked about what causes sciatica, but what are the risk factors, or are there any risk factors?
Really, it's interesting. There aren't any particular gender risk factors, but age does play into when most folks will see symptoms from sciatica. Typically that happens with people in their 40s. It's kind of rare for folks in their 20s and younger to see any incidents of sciatica. Lifetime incidence is about 10 to 40% of the population will at some time experience symptoms of sciatica, with about a 1 to 5% annual incidence of sciatica. Some people will often comment on occupations that can kind of contribute to or perhaps put people at risk for sciatica. Is there one specific occupation that does that? Well, not really. We have to think about body mechanics when we think about contribution or causing sciatica, right? Any kind of a occupation that requires you to be in awkward positions, requiring bending, twisting, kind of flexion at the waist for prolonged periods of time could put you at risk for developing these symptoms. There's not one that specifically does. Some that have been mentioned have been heavy equipment operators, truck drivers, things like that. But just think about it kind of in a more broad sense, anything that puts you in a somewhat odd position for prolonged periods of time. I'll often get the question too, well, did I cause this? Did I do something to have, result in me winding up in your office? Well, not really. These things happen to us as folks, and as we get older, the likelihood of that happening sometimes does increase with age. Interestingly, there aren't activities or sports which have been shown to precipitate this necessarily. However, if people have had prior instances of sciatic pain, then they may be predisposed to recurrence with those activities.
Awesome. So I feel like sciatica is a very generalized term. A lot of people hear it, they see it on commercials, on TV. What actually is sciatica? What are the signs and symptoms of it? And if somebody comes in, like, what are they complaining about?
How do we figure that out? Right. What are they talking about?
Exactly.
Many times with any type of a nerve root compression, we're talking about neuropathic pain is the way we describe it. Neuropathic pain is that pain which involves burning, numbing, tingling, radiating within the distribution of said nerve. Now, it could be the sciatic nerve radiating down just above the knee on the back of the thigh. It could be radiating into the sciatic nerve's component parts further down in the lower leg. Now, what would that be? Well, when we ask that question, we often have to think, okay, well, what are the terminal branches of the sciatic nerve? Well, the sciatic nerve divides into the tibial and common peroneal nerves just above the knee. Well, those two nerves are primarily responsible for innervation of the lower leg. And that can be innervation of the back of the leg involving the calf and gastrocnemius and soleus muscle. It can also involve the anterior and lateral compartment of the lower leg, and in particular, a large muscle called the tibialis anterior. Now, I mentioned that one because that one's often involved in foot drop, which is a result of a compression on an L4/L5 nerve root, which causes the foot to slap. Many of us have seen folks with that, or perhaps even experienced that ourselves at times. Now, that to go back to the original question, we can then have pain, numbness, tingling, burning, even weakness radiating into the distribution of both the sciatic nerve and its terminal branches. That can result in numbness in those areas innervated. It can result in weakness in those muscles innervated. Going back to the foot drop, that's a classic example. We can even have constant burning sensation in any of those areas. Now, when we have someone come in with that presentation, one, history is very important, right? So we want to know the distribution of that patient's pain, the quality of that pain. Obviously, severity bears on this, right? Most people don't come in if it's just a kind of minor annoyance here and there. But when the pain becomes more consistent, that's usually when they'll come in for evaluation. Some of the things that we look for are actually sensory loss in those areas innervated by the nerves we just talked about. We will also do some manual muscle testing and find out if there's any weakness compared to the other side, if it's not symptomatic on the other side. There are also some provocative tests or even physical exam maneuvers that we will go through, including things like straight leg raise and slump test and various other tests, to see if we can elicit or even recreate some of those symptoms while going through the exam.
So on my first, like if I were a patient, I was coming in, what do I expect at my first visit?
Right. So typically what will happen is we'll get a good history. We will also go through a good physical exam, including some of the sensory testing, motor testing, special testing that can elicit or reproduce some of those same symptoms that the patient was experiencing with those exacerbating factors. Kind of the next things that will happen are typically imaging studies. Now, imaging studies can be anything from simple x-rays to our gold standard for evaluating discs and nerves, which would be MRI. Now, those are the things that we will typically start first that may go on to include things like electrodiagnostic testing, which is also an EMG or nerve conduction study. The general term would be electrodiagnostics, and those tools can also be used to more accurately define which nerves are involved and the severity.
So if you confirm that you have sciatica or lumbar radiculopathy, what would you do as far as treatment? What is like the conservative to the more severe?
Sure. So typically we will start, and most people have gone through these things before, so you don't go to the doctor the first second you feel some pain, right? So most of us will kind of think, oh, well, I'll just give it some time and see how it does. Perhaps I'll take some Tylenol or ibuprofen, whatever I have at the house. Those are appropriate things to do, right? NSAIDs are appropriate for use. Tylenol has also been used because most people have that in their medicine cabinets. When that fails to produce relief, you will come on into the office, we go through the things we just talked about, and typically we will start with some therapy to address perhaps some imbalance in muscle tone. Also, that can help to ease the pain through a variety of different stretching techniques, therapeutic exercise, various other modalities that physical therapists employ. We will also perhaps get into other medicines than one would have in their medicine cabinet at home. While we may continue on with a course of nonsteroidal anti-inflammatory or drugs like naproxen, ibuprofen, perhaps meloxicam, Celebrex, those things are still indicated for these types of conditions. At that point, we may also start things like muscle relaxers. Opioid pain medication can be used. We don't just jump to that as a first line, but it's part of the treatment regimen. Other things like membrane stabilizing agents, such as pregabalin or gabapentin, are sometimes employed.
So medications don't work. Say that they're not working for you. What would be the next step up?
Sure. And that often happens, right? Especially in my clinic, people have often gone through a number of steps before they come to me. So after we have tried the things that we can do at home, those medicines that we have in the medicine cabinet, perhaps we've gone into our physician's office and they've tried something. Failing those, we've started some physical therapy. We employ some of the other medications we were just mentioning. When those things fail to produce results, we will often at that point move to obtaining advanced imaging like an MRI. In cases where an MRI is not possible, such as someone who has an implanted device that's not compatible, then we will go with the CT scan. That doesn't provide the kind of resolution we prefer, but sometimes that's our best option. When those things happen, we're looking for a couple of things. We're looking for causes, right? We mentioned early on that often sciatica is caused by a herniated or bulging lumbar disc that pushes against a nerve root. It can also be due to various changes that happen within facet joints. So what are those facet joints? Facet joints are the joints that run along the spine. Now, like every other joint within the body, those joints also undergo degenerative changes. As part of the degenerative change, we will start to develop bone spurs in that area, right? Bone spurs, if they were going backward, would not be a problem. However, many times those bone spurs can impinge upon the lumbar nerve root, right? And that can produce the same types of symptoms as would a herniated disc which is represented here.
I'll go ahead and switch over to this camera if you want to
Sure.
show that a little bit closer so everyone can see.
Yeah, we were kind of talking about the facet joints here and their proximity to the nerve root. The nerve root's represented by this yellow structure. Obviously, you can see the facet joint here. Any type of a bone spur that would then form here could impinge upon this nerve root and cause those neuropathic pain symptoms within the distribution of that nerve root. Now, there are a number of other conditions which can impinge upon the root. Any of those things, any mass occupying lesion within the space of this nerve root can end up causing symptoms of lumbar radiculopathy. Those are just two of the most common ones that we see. Now, we also we talked about before that the sciatic nerve is actually a peripheral nerve. So that peripheral nerve actually forms up. Now this is kind of a representation of the lumbosacral plexus. So this is part of the sciatic nerve, or at least contributes to the sciatic nerve, let's say. So some of the more uncommon causes of sciatica are any type of impingement between where the sciatic nerve exits the pelvis here and courses down the posterior part of the femur or back of the thigh, if you will.
So does anybody ever come in and say they have sciatica and they don't actually have sciatica?
Yes, and Caitlin, I'm glad you brought that up, because that's often one that we kind of have to figure out exactly what's going on. When a patient comes in and says, I have sciatica, I will often ask, okay, well, what do you mean by that specifically? Because all back pain that radiates is not sciatica, right? We talked about that earlier, that sciatica actually involves a specific nerve. Now, if one has pain that radiates into the anterior aspect of the thigh or the inner aspect of the thigh, that doesn't involve the sciatic nerve. That is more likely a pinched nerve kind of higher up in the lumbar spine. Could also be a compression on one of the peripheral nerves that innervates those areas of the thigh, much like sciatica, but it would not be sciatica, right? So a little bit of a difference there.
Gotcha. So if after you get the MRI or the advanced imaging, what would be your next step? And does sciatica ever lead to surgery?
It can, it certainly can. And one of the things that we will do, and one of the reasons why we use the MRI is such an important tool, is to gauge the degree of the problem, if you will, or the severity of a bulging disc. Many times that degree of severity determines where we go next. So kind of that thing that we can do in between the more conservative options we mentioned already and surgery are things like epidural steroid injections or nerve blocks, right? So what we will do in those situations is actually advance a needle down to the space or epidural layer around one of the affected nerve roots as seen on the MRI, and actually inject a solution of both anesthetic and steroid. Now, the reason why that is helpful, and the reason why we do that, is because steroids are the best anti-inflammatories that we have, right? They decrease the production of inflammatory mediators. Those inflammatory mediators become kind of a problem for us because they amplify the pain response, right? They get released because of the pinch on the nerve root, which you can see in this image here. And when that happens, a patient experiences more of the burning, tingling, numbing pain. The usefulness of the steroid is to reduce that, sometimes even completely. I will say that majority of the time you can't 100% remove the pain. You can reduce it significantly and make the patient far more comfortable. It just doesn't completely eliminate the issue, because after all, there's still a mechanical compression on said nerve root, but it's just not near as painful as it was prior to the injection. Now, you asked if the issue causing the sciatica, can that result in surgery? It certainly can. Sometimes, depending on the degree of compression on a nerve root, surgery is the best option. There are also other times when a patient's experiencing weakness or even atrophy in muscles innervated by some of those affected nerve roots. In those cases, we tend to look more toward surgery as an option because we want to alleviate the pressure on that nerve.
So we actually, a question kind of going along with what we're talking about. Miss Beverly says, my husband's pain starts on the top of his foot and up to the back of his hip. Could this be sciatica?
It could be. More accurately, top of the foot would probably be like a L5 radiculopathy, and that would be irritation of a nerve root which makes up part of the sciatic nerve, but that distribution to the top of the foot definitely kind of fits that picture.
Awesome. Well, thank you for that. Kind of moving forward, what can you expect long-term with sciatica? Does it stick around? Does it come and go? How does that work?
Right. There's a range of possibilities, right? Anything can happen. Interestingly, sciatica can completely resolve on its own. Typically if it's self-limited, it's going to be gone 4 to 6 weeks. Interestingly also, that's typically the time when people will come in for evaluation in the office because it didn't resolve, right? Now, like we talked about before, some people will get significant or near complete resolution just by taking some ibuprofen, and that's fine. Others, it takes doing other things like physical therapy, like epidural steroid injections. And then all the way on the other end of the spectrum is pain that does not resolve, also results in a neurologic deficit, which then requires us to kind of move on to the surgical option.
Gotcha. So moving on a little bit more, we've kind of covered what sciatica is, decoded it. Are there any complications with sciatica, like long-term effects?
Yeah, that all depends on how affected the nerve roots are that are making up the sciatica and therefore responsible for that pain. Now, if a nerve root is compressed badly enough for long enough, yes, you can result in permanent changes to fibers of that nerve root and therefore muscles innervated by that nerve root. However, the majority of patients will not have long-term sequelae with sciatica. Those things will kind of ebb and flow. They will at times experience severe pain, which then subsides somewhat. Oftentimes, like we mentioned before, if there's a patient who has previously had episodes of sciatica, can certain activities, playing golf, it can make it worse, I'm sorry. I know I hate it too, but can that reproduce some of those symptoms? Yes, it can. So oftentimes a patient who's had previous episodes of sciatica kind of has to go through some activity modification and learn kind of what things they can and can't do that don't exacerbate their pain.
Very good. Now, what kind of activities help on a daily basis?
Yeah, the big one for that one, and I share this with patients in clinic all the time. Core strengthening is probably at the heart of what you'll hear and what you'll see on the internet. What's that mean? Basically ab strength, right? I mean, there are other parts to that, but that's the part that's often deficient, right? As we age and we go through our jobs and our careers where we sit a lot, our core strength diminishes because we're not engaging those postural muscles. Now, we can't leave out the other important, the erector spinae muscles or lumbar paraspinals are also essential for maintaining good spine health and therefore not moving to sciatica, right, or not developing symptoms of sciatica. The other side of that coin, so strength is great, right? We can't just have a hypertonic muscle though, so gentle stretching also helps. The old hanging leg, hanging stretch where we would stretch our hamstrings from gym class way back in elementary school, that still helps. There are a number of other stretchers, home exercises that we often will give out in clinic. There are exercises that one can find on YouTube or various other platforms that do kind of guide you through how to do more advanced things. But if we keep a strong, flexible core, we're likely to benefit from that long term. Now, when we do develop the symptoms, things like heat to the affected area, sometimes cold if the symptoms are very acute, like we went out and worked in the yard or went out and played golf or went out and did whatever, and everything just kind of flares up that night. That's the place where ice is really helpful. After about 48 hours, heat is often more helpful than the ice.
Lashana asks, does stretching help? I know you said core strengthening. What about stretching, and what kind of stretches?
Stretches do help. Any stretch that can gently stretch hamstrings, paraspinal muscles, glutes, calves are going to be helpful in decreasing symptoms related to sciatica.
Now, if someone has surgery for sciatica, this is another question coming in from Thomas. Does therapy help after surgery?
It certainly does. One of the things that we have to think about whenever we have surgery to address a herniated lumbar disc is that, one, there's some scarring that happens. There's scarring that happens anytime we make any type of an incision or if you have any kind of an inflammatory condition. So one of the things that can happen with that is that we can lose mobility in those lumbar paraspinal muscles that we previously discussed. We can also get some kind of shortened musculature within our extremities as well, some of the glutes, hamstrings, calves, quads even. So that's where therapy really helps. And therapists are great because they can kind of look at a person's movement, like actually define those deficits and those imbalances and then work to address those things.
So another question here from Carolyn. She asks, does or will a 30-minute daily walk help? And is there any consequences, I guess?
Is there any, right, are there any risks with that? I wouldn't say a 30-minute walk would negatively impact sciatica at all. It actually can help out quite a bit because what's that doing? You're actually warming up the muscles, which often helps. You're decreasing pain due to the fact that you're making those muscles involved in walking more pliable, right? So as we get up and move around and get some movement within the muscle, you actually decrease the tension and actually help alleviate some of those sciatic symptoms.
All right, so you talked about one of the treatments for an injection is, one of the treatments for sciatica is an injection. What is kind of the recovery time for that injection?
Yeah, that's interesting. So unlike having surgery, there's no time to heal. Once the steroids are in place, you can have some tenderness from the injection site. Some folks will even experience what's called a steroid flare, where for a couple of days, they actually have some increased pain. However, after about 3 to 4 days, the majority of folks who receive those steroid injections will start to feel the effect or the results of those decreased inflammatory mediators we talked about earlier. Sometimes that takes up to 2 weeks to fully take effect. Most of us see improvement in 3 or 4 days, though.
Awesome. Another question talks about from Miss Antoinette. She says she has pain when she sits down and in the back of the thigh. Is that for that? Has it been, could that be sciatica? Could it be something else with more pain sitting down?
Could be. There are a number of things that can cause gluteal pain that radiates into the proximal portion of the thigh, posterior part. That can include sciatica. That can include lumbar radiculopathy, which we mentioned earlier is a component part of the sciatic nerve. That can be the SI joint. That can also be the hip joint itself. So there are a number of things that can typically cause that pain, but it is potentially part of it. Yeah.
Gotcha. Her question a little bit further down goes into, she doesn't necessarily have back pain all the time. It may just be in her leg. Could that be possible with sciatica?
It can be. Oftentimes, whenever we have a patient with sciatica / lumbar radiculopathy, they will have little to no back pain and have primarily leg pain. So absolutely, that's a potential cause.
And if it gets worse during the day, is there anything that you can do to kind of prevent it from getting worse throughout a long day?
Yeah, that's a tough one. Sometimes bracing does help. And why would bracing help? If we use a corset style brace, we kind of think about it, you're squeezing the contents, right? So when you squeeze the contents, you actually kind of support that height between our discs here. So as we squeeze the abdomen, we kind of support the fact that this has the height that it normally does. If we let things kind of sag, it can sag and put pressure on the nerves. Hard to pick that up in the camera. It's almost like having really excellent posture all the time, right? If we all did that all the time and didn't sag, would we have as much back pain? Probably not. And bracing does the same thing. Now, if we are having kind of pain that increases through the day, then doing those things like putting an ice pack on to the affected area, perhaps taking some NSAIDs like the ibuprofen and that naproxen can kind of get you through the day a little bit further. But those are things that you can do. There's some stretches that you can engage in throughout the day that do kind of help loosen things up and possibly provide you a longer interval of pain-free activity.
Gotcha. Another question from Colin says, how long does it take for the sciatica or the sciatic nerve to heal after a microdiscectomy, which is the surgery?
Yeah, so the sciatic nerve is not the structure that has to heal, interestingly enough. It's that nerve root which makes it up. So can that heal almost immediately? Yes, it totally depends on how long the compression was there, right? That there's definitely a linear correlation between duration of compression and time to full resolution. Sometimes a nerve never fully recovers. However, that's not the norm, right? Those are more rare cases. Typically within the 3 months of full recovery, a patient will see tremendous recovery after microdisc.
Awesome. All right, so moving a little further down, let me take a second and look. Okay, so Miss Lynn, she says, I have constant lower right back pain at my hip. The pain does not radiate. Could this be sciatica?
Not as likely, right? So sciatica, like we talked about before, does by definition radiates into the distribution of that sciatic nerve. When it's just isolated to a spot on the low back, it's likely another cause. Could be those facet joints that we were briefly mentioning earlier. However, that's a kind of a different topic than this one, but associated, right? So all of these things kind of, you can't separate all the parts out. They're all joined together. So I would say that's not likely to be sciatica, but one of the component parts, perhaps, or more likely, one of the facet joints there.
Gotcha. And now, is sciatica, if someone has like a total knee or a total hip replacement, is sciatica normal, like a common thing after that surgery?
Not necessarily. No, it would be a different entity. Yeah.
Gotcha. Well, we've talked about decoding sciatica. We've talked about what it is, what causes it, the risk factors, kind of how you treat it. Is there anything else you'd like to add?
I think we can open it to questions. That kind of gives you a brief overview of what it is, what it's not a little bit, how to treat it, what it typically feels like, right? And the course that most patients will go through when they have these symptoms that don't just resolve on their own.
Yes. Awesome. 2 last questions,
Sure.
and then we'll make sure we get all the rest of the questions to you after we
Right.
finish tonight. What is your opinion, or do you think inversion tables help?
Yeah, and if that's one of my patients, good listening in there, right? Because I often do talk about using inversion tables. For folks that can use an inversion table, folks that don't have cerebral aneurysms, folks that don't have significant amount of heart failure, variety of reasons why you wouldn't want to use one. However, for most of us, it does provide some relief, right? It's a very easy way using our body weight to basically provide lumbar traction, right? So we're using our body weight to go into somewhat of a negative, right? You don't have to be straight up and down like on the teeter hang-up commercials. You can be, at a negative 45 and still get relief. Oftentimes, if you go to those lower degrees of negative, it's actually more comfortable, right? So you kind of want to progress into that. But yes, I think inversion tables are a great tool.
Awesome. You mentioned causes for gluteal pain.
Mhm.
Can you kind of go into that just a little bit more, and the separation between like in your gluteal versus a sciatica?
Right. So if it's just gluteal pain, you won't have that radiation further down into the posterior aspect of the leg, right? So those causes of pain that just involve the glutes are probably less common because herniated disc or bulging discs are the more common cause of that pain, which radiates further down the leg. However, gluteal pain can be a couple of things. Sacroiliac joint is a classic pain generator that causes pain within the glute, as well as hip arthritis can cause that. Interestingly, hip arthritis can present with posterior hip pain, which is glute pain, can be groin pain, and can be lateral hip pain. It can be all those things, or it can just be one of them, right? So that's the tough part. Sometimes we have to go through a few things or a few tests and procedures to see basically which one of those things is the main presenting complaint. However, there are tests. Imaging helps with that quite a bit. Provocative tests can help with that quite a bit. So there are certainly ways to distinguish it.
Awesome. Well, I feel like if it gets more complicated, then you need to come in and make an appointment
For
and
sure.
see
for
Dr.
sure.
Stewart.
We'll be glad to see you anytime.
Yes. Any last remarks before we close tonight?
No, hopefully that shed some light on this topic. I know it's kind of it's a label that gets applied to a lot of things that may or may not be sciatica. So if we did anything, I hope that we kind of cleared up some of that tonight.
Yes, awesome. Well, thank you so much for joining us. Thank you all for watching. If you are wanting to make an appointment to see Dr. Stewart or any of our providers, that information will be displayed right after this. So thank you guys so much for watching.
Thank you.